Type 1 diabetes is a disease that is most familiar to people as it strikes young children, but about half of the people affected by this disease are first diagnosed in their adult years. Fortunately, there is a cure, so to speak, or a treatment, I should say, more accurately, for this disease in the form of insulin, which we've had now for 100 years. But I think anybody with type 1 diabetes will tell you that insulin is far from the answer for this disease. It's a lifelong daily burden that means being connected to devices or to self-administering insulin. So there's a huge unmet clinical need there. And we work in two areas. One is in the area of new onset. So these are people who've just gotten a diagnosis of type 1 diabetes. They've been told they're going to be on insulin for the rest of their life, but there's a window there where they still have a few functional islets that if we can get to them, maybe we can reverse that disease or preserve some of their own insulin production that will translate into much better outcomes as they go through their life. The other area, the one that I'm very excited about, is this idea that we can intervene long before there's a diagnosis. Type 1 diabetes is one of these diseases where we understand a lot about the natural history. We know people begin to develop this disease years, sometimes decades before they're actually diagnosed. That gives us a huge window where we can potentially intervene, ideally stop the disease dead in its tracks, but perhaps delay that for some number of years, which you can imagine if you're a parent trying to take care of a 3 or a 4-year-old. Well, if we could delay the disease until they're in their teen years, better able to help with their own care or to get somebody through high school or through college, these are all things that could really benefit families and the affected individuals. So we won't let perfect be the enemy of good, but we won't stop striving for perfect. One of the things that CPath does, not just in type 1 diabetes, but across the board, is take what has been done in the world of academia, or sometimes in the world of industry, and bring it to life. So in the case of type 1 diabetes, we've known for at least 30 years that autoantibodies, the presence of islet autoantibodies in the blood, were a biomarker, a predictor of disease. If you had 2 or more of the 4 autoantibodies that we commonly look for, it's no longer a question of if, but when are you going to become diabetic. That academic knowledge was great. The reality was no one had aggregated that data and brought it to the regulators in a way that they could assess it. And so this is how I actually became acquainted with the Critical Path Institute. In my former role at J&J, leading their type 1 diabetes effort, we started working with Critical Path to try and get this data in front of regulators. We took it to the EMA for a qualification opinion, and the EMA agreed that yes, these biomarkers are suitable for enrolling patients in clinical trials before the onset of symptoms, which for us, or for the T1D community, was a huge win. So taking that academic information, translating it into regulatory science that then enables the regulators to make critical decisions, I think is what CPath, I think that's the heart of our mission, really.